First of all, I want to appreciate President Harap for giving us very precious opportunity. Our society CSRS AP was founded in 2010 as a sister society of CSRS and CSRS European section. As we are the youngest society, we have been struggling to catch up even a little in the history of about 12 years. As you know, more than 60% of the world population lives in Asia-Pacific region, and many patients are suffering from cervical spine diseases. Among them, there are many intractable cases involved. Today, we want to introduce 5 categories of intractable cervical disorder we have confronted in Asian countries. Our education committee selected 5 surgeons who are leaders to treat them in each country. First topic is infectious diseases in cervical spine, presented by Dr. Rajasekaran from India. Second is severe deformity, explained by Dr. Suk from South Korea. Third topic is hyperkinetic cervical spine, mainly in athetoid cerebral palsy patients. I am in charge of this topic. Next intractable disorder is drop head syndrome. As the aging society advanced, this disease is increasing in Asian countries, including Japan. Then Dr. Ishii will present it. Last topic is tumors, including of metastasis at cervical spine. China, the world's most populous country, is actively working to treat very difficult tumors in cervical spine. Dr. Feng Wei from China is a speaker of this topic. As you know, cervical spine locates between head and heart and play an important role as a human lifeline. Therefore, we cannot run away from intractable cervical disorders. That is the reason I pick up them of CSRS AP 2023 as cervical spine between head and heart. If you are interested in our struggles and experience, please join our meeting in Yokohama, Japan. Then let's start the session. First speaker is Dr. Rajasekaran. The title is Infectious Disease in Cervical Spine.
Good morning. Thank you very much for the opportunity for discussing on the problem of gross deformities following infections in cervical spine. I bring to you warm wishes from CSRS AP, and there are no disclosures. Now, pyogenic infections rarely give rise to a gross deformity. Deformities are more common following tuberculosis, but even in tuberculosis, a cervical deformity is rare because only less than 10% of spinal tuberculosis involves the cervical region. Also, the anatomy that the cervical spine is very mobile and does not have the thoracic cage to support it, and also because the facets are easily subluxable. Instabilities are very common and they give rise to a lot of pain, and so the patient comes supporting their head even with mild infections, and so they present early. Now, if you see the natural history, we find that unlike the thoracic and the lumbar areas where paradiscal infections is very common, cervical spine infections have whole body involvement, and so entire bodies are destroyed, leading to an acute collapse and angulation. Later, the facets easily sublux, leading to gross kyphosis. Here you can see that there is a whole body involvement over here, which leads to a functional destruction of the posterior column, and that leads to an acute angulation, and this can lead to a buckling sort of collapse if 2 or 3 more facets dislocate. Now, the management actually involves prevention, and whether the disease is active or healed, the location of the disease and severity all come into consideration on what we do. The first scenario is where the anterior column alone is deficient, the posterior column is intact, and there is no major subluxation or instability. You can see over here there is a C5 complete destruction of this patient, but the posterior column is intact and there is no subluxation. And in these patients, what is sufficient is to reconstitute the anterior column, which has been done by an iliac crest graft here. There is no need to do a posterior column reconstruction in such patients. The anterior column reconstruction can be done either by an iliac crest graft or more commonly nowadays where a Harm's cage of titanium cages are used for reconstruction. Again, you can see over here, because the posterior column is completely intact, we have not done anything to the posterior column. Now, this is against the scenario 2, where there is an anterior column is deficient, but there is a functional deficiency of the posterior column by facetal joint dislocation. So there is instability and kyphosis. To assess the instability, we use the spine at risk radiological signs, which was described by us in 2004. Now, here is a typical case. You can see in this 13-year-old female, there is a C7 complete loss. You can see that the whole body is gone and all the spine at risk signs of posterior translation, acute angulation, and facet joint dislocation all are present over here. In these patients, it is important that there is not only an anterior column reconstruction, but there is also a posterior column stabilization over here. Use of pedicle screws allows us to limit the number of segments that are fixed so that the spine is very mobile. Now, if you look at the other scenario of upper cervical lesions of C1 and C2, most of them can be treated conservatively, but they can also present with gross instability, especially when the odontoid and ligaments are compromised. You can see here that C2 base and probably the odontoid is gone, but it is not very visible in the plain radiographs and in the MRI. But CT is always essential to show how much of subluxation has taken place. And here you can see it is not only in the AP view, but also there is a gross lateral subluxation, a very unstable situation which requires immediate stabilization. Now, I would like to point out a special feature of TB, that unlike in tumor or in other areas where when there is a gross destruction of the anterior column, you need to reconstruct the anterior column. In TB, when you stabilize the posterior column very well, and you bring bone and bone close to each other, and when you put them on chemotherapy and good adequate drugs, you can find that the entire anterior column completely reconstitutes by itself without the need for a separate anterior column reconstruction. This is a unique feature of TB. The same principle has been followed here, where there is an extensive lesion of the cervicothoracic spine. And you can see that multiple vertebral bodies are gone. And if you do a thorough debridement on the anterior side, you will find that most of these bodies will be completely gone, and you have a tough situation on hand to reconstruct more than 5 vertebral body loss. Again, the same principle was followed, that the deformity was corrected, and you have actually given a good stabilization. And once you put these patients on adequate drugs, the entire anterior column reconstitutes and fuses by itself without the need for a massive anterior surgery. Now, the last scenario is a healed severe kyphosis. Now, here you can find a 6-year-old female who presented with neck pain and progressive deformity, who had already been fully treated with antituberculous drug therapy for 1 year. Fortunately, there was no myelopathy. Now, this patient, you can see all the radiological signs of instability. You can see that there is a complete toppling over. The facet joints are completely dislocated. And in TB and infections like this, we need to remember that when you take a wedge, that the anterior column wedge is very small, but it represents almost 2.5 vertebral bodies. And so when you do a wedge and you reconstruct, you need to be careful that adequate posterior decompression is done so that there is no kinking on the cord. In these patients, there is often fibrous union, and here you can see that with traction, there is a good correction. That makes the actual surgical correction much simpler. And with an anterior and posterior surgery, we find that there is a good correction. And in this patient, you can see that after 2 years, a very good solid bone formation has been formed both anteriorly and posteriorly. So, in conclusion, deformities are uncommon in the cervical spine and they are more common in TB. But as less than 10% of TB infections are in the cervical region, their gross deformity is still held. Management depends upon activity of the disease, location, and severity. And use of pedicle screws with navigation allows accuracy and limitation of instrumentation to fewer segments so that the mobility of the cervical spine is still maintained. Thank you very much for this opportunity and warm greetings to all of you.
Thank you, Raja.
Thank you, Professor Mehara, for this opportunity.
Are there any questions? So I have one question. So we always feel difficulty when the infectious disease is from tuberculosis or common bacterial infections. How can we distinguish tuberculosis and a regular bacterial infection, and what's the difference in treatment strategy?
Thank you, Professor Mehara. So the differentiation is either in radiology, clinical, and also bacteriological. So the way they present is very typical. TB is very chronic, it goes slowly. Sometimes you get huge involvement of the cervical spine with very little pain. And that is why there is a lot of bone destruction and the patient comes with kyphosis. But pyogenic infections are more precipitous. They have a lot of febrile reaction, there is constitutional symptom, and also the symptoms are very, very acute. In radiology, especially the MRI, if the bones are more involved with the disc being intact, and there is an abscess which goes subligamentous across more than 2 vertebral bodies, then it is usually TB. In all cases where we have a doubt, we do a CT guided biopsy and do a gene expert. So we have to be sure on what is the bacteria before we start the treatment.
Mm-hmm. Thank you so much. Okay.
Thank you.
Any other questions?
I would like to additionally talk about the differentiation of the TB and pyogenic infection.
Yeah.
In the pyogenic, the bacterial infection, there's a collagenase which found at the pyogenic bacteria. Therefore, more lytic lesion or more destruction of disc material. But TB spine, disc material is more preserved compared to the bony destruction. And the pyogenic and the TB infection is more slowly progressed, therefore more abscess formation compared to the pyogenic.
Okay, thank you.
Thank you.
Thank you for your advice. Okay. So I have one message. So when we confront the very tough case, we should observe and take very carefully examine the patient neurological condition. And after that, when we perform the surgery, we should keep original structures as much as possible and make reconstruction using such original structures. That is my most important message to you. So thank you for listening this session. So we enjoyed discussion. Thank you. Thank you, the lecturers. Thank you all.
Thank you.
Thank you very much.
Thank you.